Thank you. So I'm Michael. I'm a breast surgeon and an epidemiologist.
乳腺外科医生，他同时也是流行病学的博士。
I'm going to share with you an evaluation of the Singapore breast screening program.
现在他要介绍一下新加坡的那个乳腺筛查的一个国家的一个项目，是 national program.
National program. And I'm going to hopefully convey how difficult it is to do breast screening in Asia.
然后希望也让大家知道说，要成功的做乳腺筛查，推行这样的一个项目是不容易的。
And that's probably going to be my most important message.
这个就是今天的关键的一个信息。
So I'll talk a little bit about a background.
所以现在先给大家一个背景。
Aims, method, results, discussion, and then some of my own conclusions and recommendations.
然后接着就会介绍他的这个研究的那个目标、方法、结果、讨论，然后最后呢就是他自己的一个建议跟推荐。
And if you don't agree, I'm very happy and we can discuss.
所以之后假如大家有任何的想法、建议、疑问，请踊跃的提问。
This is probably one of the most loaded areas within breast cancer at the moment.
这个在整个乳腺肿瘤的这样的一个领域里面呢，应该是相当具争议性的一个课题。
This is breast cancer in Singapore.
这个是新加坡乳腺癌的现状。
From 1993 until present day, this is the incidence of breast cancer.
从93年到现在的一个发病率的一个趋势图。
It has been increasing quite dramatically.
然后它从93年到现在，这个很戏剧性的增加。
I suspect it is the same here in Kunming.
然后他也怀疑，基本上在昆明、在云南也应该是同样的状况。
But I don't know. At the same time that it's getting more common, the risk to die of breast cancer in Singapore is getting less common.
虽然说那个新发病率是节节上升，但是那个死亡率呢却是下降了。
So the mortality of breast cancer is coming down.
所以你们看那个趋势图，死亡率是下降的。
The question is this due to screening or treatment?
所以大家要解决的问题是，这个死亡率的下降是因为治疗越来越好，还是这个筛查的效果？
So the background to screening are these randomized trials.
所以就是展示给大家看，就是这个是乳腺癌早期筛查的一个循证的一个依据跟基础。
Many of them are from Sweden, where I am from. Some are from the United States, and some are from Canada.
当然要注意的是，有好一大部分的这个所谓的循证医学的依据呢，都是从美国、欧洲、北欧、瑞典，就是他的老家。
Except for 2 trials in Canada, a benefit of screening.
除了其中一个加拿大的那个研究的结果除外，其他的都支持乳腺癌筛查能够减少。
Which is important when we talk about the Canadian long-term evaluation.
就是刚才这位老师他刚才有提到的，这个加拿大它的一个很长期的跟踪的一个前瞻性的一个研究。
Because the Canadian study started out without showing much effect.
所以那个加拿大的研究，它是初期的时候基本上没看到太大的效果。
So these studies show that if you go for screening, your risk of dying from breast cancer is 20% less.
You mean all these studies?
Collectively.
所以就是总的来说，你做一个荟萃分析的话，总的来说，你去接受筛查，你的死亡率能够减少20%。
And because of this, breast cancer screening was started in many
所
countries.
以因这样的基础呢，在各国都开始了这个筛查的项目。
So how can we evaluate if it actually works?
那我们可以怎样的真的评估这个筛查的这个效果呢？
So this is a result from England and Wales,
是英国跟威尔斯他们的数据，
showing the risk to die from 1950 until 1980, the risk is increasing.
然后他们 这个趋势图呢，就是从50年代到80年代呢，它的那个死亡的风险是上升的。
In
死亡率。
1988, the risk of dying started getting less.
但是你注意到说，80年代然后到90年代那个死亡率就开始下降。
Was this due to screening or treatment?
所以问题是，这个是因为筛查还是因为更好的治疗？
The authors think that it's a combination of screening, better treatment, and better healthcare delivery.
所以这项研究者他们的结论就是都是多因素的，一方面是有筛查，一方面是治疗更好，一方面是整个医疗体制它在进步。
Which poses the question whether or not one should have a national screening program or not.
所以因此就很多人问说，我们到底是不是需要一个全国性的一个普及的筛查的项目？
There are two fundamental problems when evaluating a screening program. You may know them, but I'll go through both of them.
但从科研跟流行病学的角度，你要去评估这个筛查到底有没有效果的话，是有2个根本性的问题。
The first thing has to do with how quickly tumors grow.
第一个就是跟肿瘤的那个疾病的病程的速度很有关系。
So if you're a hunter and you go hunting for animals, you'll pick the slowest running animal.
假如你是猎人 ，Do you hunt in Sweden?
Yes.
在瑞典他们喜欢去打猎哈，所以你打猎的话，你肯定是去找那个跑得最慢的动物。
Okay. The fast ones will escape you.
所以因为那些跑得很快的，肯定你就猎不到。
So if you do a mammogram
所以当你做
here,
木靶的时候呢，在那个点你做木靶。
you will only catch these 2 cancers.
你只能抓到那个非常恶性、病程非常快的那2个案例。
If you have slow-growing cancers, you'll catch more of them.
但是，假如那个肿瘤的疾病病程速度非常慢，你能够筛查出更多。
Because from diagnosis until being a lump, they're there longer.
因为从诊断，diagnosis to there being a lump，就是你从筛查出它有癌变到它演变成一个包块，那个病程是相当长的。
Okay. The second problem has to do with something called lead time.
第2个问题，这个叫做先导偏差，你们叫做先导偏差，还是这个领先时间偏差？
Okay, I'll walk through this. First, cancer cell.
OK， 没关系，我们用图表的形式来
Okay,
表示。
a lump.
OK， 所以它刚才指的是那个发病的那个点，直到它开始有症状，就是有个包块。
Detectable with a mammogram.
然后它现在指的就是你，假如用木靶来筛查的话，你能够发现那个癌变的那个点。
Clinical diagnosis can be done here.
然后一般呢，所谓的临床诊断是等到有包块了之后。
If I do a mammogram, I can find it earlier.
假如你做个木靶的话，你可以在它还没成一个包块，你就能够发现有问题。
This time is called lead time.
所以那个临床诊断跟那个早期诊断之间间隔的那个时间叫做 lead time。 我的翻译叫做先导。
If I calculate survival time, it starts from diagnosis.
所以当我们计算所谓的生存时间的时候，都是从那个诊断的时间那一点开始。
Yeah. So my survival time starts here.
所以生存时间就从那个诊断的那个点开始。
But I haven't done anything good here.
What do you mean?
I haven't increased the woman's life expectancy during this time.
Which means whether you find it early or clinical, they will die at the same point.
I don't know yet.
OK， 所以假设呢，我们假设这个肿瘤，你即使是早期诊断，或者是等到它有症状了、包块的时候才诊断，它都是同样的死亡点。这样的话呢，你基本上早期筛查没有任何的益处。
Because I want
这
to.
个可以理解吗？
Yeah. So I want to postpone death.
所以第2种情况是我们想要看到的，就是你早期诊断，你确实使到他的那个死亡的时间能够往后延，这样才所谓的真正意义上的。
But I added a lot of time here in the beginning that isn't doing any good.
所以这个所谓的 lead time 的概念，就是说你虽然早期诊断，但是它还是同样时间死。这个所谓的 lead time。
And I can't take the two apart.
That's very, very well done. Complicated, very well done.
Yeah.
Okay, so in Singapore, because breast cancer was very common,
所以在刚才姚教授也有提到，在新加坡的这个乳腺肿瘤的这个发病率是节节上升。
they had to do something, so
所
they
以
did.
国家就投入钱。
So they did a randomized trial.
那他们同时也给钱做这个随机对照的临床研究。
But they didn't use death, they used intermediate markers.
但是他们评估的结果不是那个所谓的死亡点，而是一些终极的一些变量的。
They looked at incidence, stage, and treatment.
他们评估的结果就是发病率，检出的那个肿瘤的那个分期，以及那个 what's the next one? Incidence, stage and 还有病理
treatment.
还有治疗。
And these are good surrogate markers that screening may work.
所以这些的话。
So in 2002, the screening program started.
所以02年的时候就开始这个国家的普及筛查。
Yeah. So what we have done is now I'm going to give you the evaluation of the screening
所以
program.
现在就介绍它的那个评估的方法。
So we have patients diagnosed from 2002 to 2010.
然后他有一组病人就是02年检出，一直到跟踪到2010。
So about 210,000 women were invited into the program.
所以在这期间呢，有总共那么参加这个国家的筛查。
During a time period before screening and during screening, we have 24,000 cancers.
然后他们也有2个对比的时间段，一个就是93到02，一个是02到10，然后他们就也括那整个期间的所有诊断为。
So we can compare the risk to die before screening and during
所
screening.
以就能够对比国家筛查开始之前跟之后的对比。
Now, the first thing that struck us is that the number of women that have actually gone for screening is about 5 to 8% of all eligible women.
所以结果中最突出的就是在新加坡只有5%到8%的妇女参加了这个国家的普筛。
Do you think this is a lot?
你们觉得这个理想吗？
No.
很差，
It's very, very little, right?
非常的不理想。
Now, I must say, I've looked at the screening data. It's really, really a good program.
但他因为他也很熟悉这个筛查的项目，这个项目的设计是基本上是非常规范。
But despite that, the women aren't going there.
那虽然说这个设计非常规范，很好的项目，但是女性不要参加。
And we don't know why. I'll give you an idea.
所以我们要问这几个问题是为什么？
So this is Singapore's self-reported mammogram. So we asked them, have you ever had a mammogram?
这个数据的话是女性她自己说，我有去参加过乳腺筛查
40%.
40%。
United Kingdom, 74% go for screening.
英国是74%的参与。
Australia, 50 to 60%.
澳大利亚。
Sweden, between 70 to 80%. Singapore, less than 10.
新加坡少于10%。
Do you think that it's different in Kunming?
你觉得在昆明的所谓的参与率上，会不会比新加坡的好？有没有像瑞典这样？
Maybe. Huh?
They're doubtful.
Yeah, they're doubtful. Of the women that came to the screening program, 50% only had one mammogram.
另外一个结果是，参与这个筛查项目的一半以上只做过1次的木马筛查。
Which isn't really screening.
那这个严格来说也没有任何的筛查的意义。
Because you should have many tests.
因为你需要好几次的才有意义。
Okay. So we try to understand what factors women go for more tests.
所以这个研究要检出说有什么因素影响因素。
So now we compare factors of women who just had one versus two or more.
所以他们对比两组妇女，一组就是只做一次，仅做一次，另外一组是做过2次以上的妇女。
So if you ever have a job, you're more likely to go for more mammograms.
所以他们发现说，无业跟有职业是有差异的，有职业的比较多会去参加更多的木靶筛查。
The mammograms are subsidized, but the patient still has to pay a little bit.
虽然说国家有津贴那个费用，但是那个妇女还是要掏腰包。
Goes for a mammogram, does she pay or is it free?
在昆明这里是免费还是要付费的？还是要付费？
Have to pay.
大概多少
How much?
？100元。哦，对，但是那个费用是多高？ So it's zero subsidy is 180 yuan.
Okay. It's
$30.
yeah, okay.
35.41.
Yeah, so it's still okay.
因为我们差不多一样。那我看应该是有 I think it's subsidized already.
开始有津贴了吗？在昆明
Yeah?
有医保哦，so can use health insurance.
Yeah. Can you say okay? Yeah. The second thing we notice is that women who have low education are less likely to go.
他们发现了另外一个影响因素的影响妇女使用筛查的行为，就是教育水平。
And also the highly educated, but we feel the highly educated go to private doctors.
所以教育水平越高，他就越多的会想要做更依从筛查，
Women with a family history go more often.
或者是他自身或者有家族史，就是乳腺癌跟卵巢癌的家族史。
What kind of cancers do we find in the screening program?
然后我们检出的肿瘤呢，它的那个情况是怎么样的？
But remember, you're more likely to find slow-growing, nicer cancers.
所以还记得刚才有提到的一个现象，就是你的筛查项目呢，有更高的可能性会发现那些这个病程比较慢的肿瘤。
So outside of BSS, only 2% of the cancers are stage 0.
所以他们也做了一个对比，就是这个国家项目的结果跟那个国家项目以外的那个木靶的结果，然后他们对比发现说，在那个国家项目的以外所发现的肿瘤呢，它的那个原位癌的那个率比那个在国家项目内所发现的那个原位癌的率低，是吗？
And 7% inside the screening program.
7%、2%。
Outside the screening program, 12% stage 4.
然后国家项目以外的12%的远处转移的，就是他们检出的时候已经远处转移了。
In terms of grade, the low grade is more common.
然后在这个国家项目内检出的呢，它的那个病理的那个分级比较
So you find
低，是吗？
earlier cancers that are slower growing.
所以这个又证实了刚才我们提的那个现象，就是你能够检出的肿瘤呢，一般这个病理分级比较低，然后比较不那么。
So now we're going to compare survival before screening and during
然后
screening.
现在要对比那2个时间段，93到02、02到10的那个生存。
This is the 10-year Singapore breast cancer survival in 1993 and in 2000.
所以有2条线，蓝色的就是那个93到01的这个10年生存率，然后02到10就是那个10年生存率。
So there's an absolute benefit of 10% survival during that time period.
所以看到就是对比这2个时期的话，你可以看到一个10%的一个提高那个生存率。
Which is quite a lot on a population level. There are a lot of lives.
所以从人口的角度呢，这样的一个幅度呢是相当大的。
Skip this. Now, we also wanted to see if you attend the screening program many times, if you have better survival.
所以接着也要分析的就是说，你参加的木靶筛查越多，是不是你的生存率越好？
And it seems like it, although it's not statistically significant.
所以看这图表的话，好像似乎是有这样的一个关系，但是呢，没有达到这个统计学。
So, old 1993, one mammogram, many mammograms.
所以蓝色是从来没有做过，红色那条线是只做过一次，然后绿色的就是做过2次以上。
So if we now look at the risk to die, whether or not you have many mammograms when we do it, when we take into account many factors.
然后这个呢是要分析这个死亡的那个风险比值。
The risk to die of localized cancer is half as compared to not going for screening.
假如你做过2次以上的木马筛的话呢，你的那个风险比值呢，比你从来没有做过的低 ，is it half?
Yeah.
OK， 低了一半那个风险。
So it seems like those that attend screening more often do better.
所以总结下来呢，你接受的木靶筛查越多，你的那个死亡风险就越少，越低。
The problem is here, we cannot say if this is actually true.
是有一个所谓的你解读的问题，因为有好多的偏差，你要考虑。
Although it looks very encouraging.
虽然说这个看起来是相当令人鼓舞的。
So if we compare the risk to die before 1993 to 2000 as compared to just the 20% died, just crude, versus 15% in more recent years.
所以这个是对比2个时间段的那个死亡率。所以93到01是20%，02到10就是15%。
But a lot of this is probably a treatment effect.
但他认为呢，很大一部分的这样的一个幅度的减低，很大程度是因为那个治疗越好，越来越好。
So if we look within women that go to BSS,
那假如我们对比说在国家筛查项目内跟国家筛查项目外的妇女呢？
look at the number of women that actually died.
那你看到那个死亡率呢，有很显著的不一样。
It's only 6% of the women in the screening program that died.
在国家筛查项目内的呢，只有6%。
Versus 18% in women that didn't attend screening.
对比项目以外的妇女，她们的死亡率是18%。
That's a very big difference.
那这样的是一个非常显著的差异。
Okay, let's see if we do this. I think I'm going to skip this. So, in summary, our data suggests
所以现在要讨论一下啊，这个数据它有什么意义呢？
that our screening coverage is very low.
第一就是提示我们国家的这个妇女筛查乳腺癌的那个覆盖率还是相当的低。
And that most women just had one mammogram.
然后即使是参加了次数也是非常低，只有1次。
And those who were diagnosed with breast cancer in the screening program had very favorable outcome.
但是令人鼓舞的是，在这个国家筛查项目内的妇女呢，她们的死亡率呢是相当的低。
The large improvements in mortality can be attributed mostly to treatment.
所以这个死亡率的改善啊，可以归功于治疗水平的提高
and health system.
还有卫生系统改革的那个效应。
So these are some personal feelings.
所以这个就是他的一个个人意见。
So if Singapore is going to continue, it can do 3 things.
所以假如新加坡要继续的推行这个项目的话呢，可以做3方面的改革。
Either it has to get women to come to its Rolls-Royce. It's a very good program.
它要么就是要增加覆盖率，增加促进依从性参与率。
Or we have to do what Philip mentioned. We have to women depending on risk.
或者是第2种方案呢，就是要做一个个体化的筛查策略。
Or we skip this entirely and we focus on maximizing treatment.
当然还有第三种方案，就是完全放弃前两者，只注重说治疗要做得好，使到那个生存率啊。
When we ask our Ministry of Health, she says, I can only do one thing at a time.
所以当他跟卫生部谈的时候，他们说我们只能够选择其中一个方案。
But she is a politician.
但话又说回来，他是一个政治家。
I think I'm going to stop here, I think.
所以就会到此结束。现在大家有什么要交流的吗？
I'm actually going to start with the first question. Does screening work in Kunming for breast cancer?
所以他想了解一下各位专家啊，你们的专家意见，你们认为筛查有否帮助？所谓的帮助就是对死亡率啊。
就问一下，就是你这个筛查里面，因为新加坡吧，他们有没有真正的土著居民，对吧？
Do we have like a true native tribal ethnic people like in Australia or America?
We do. They are called bankers.
啊，他开玩笑，他说在新加坡有银行家，他们就是土著，土豪。没有，但是没有，就是没有啊。
如果就是在新加坡生活的，就是几代人的，或者就是移民的，因为他移民的人很多，就在筛查的时候，我们也发现，这个移民的发病率高，还是就是原来几代人都在新加坡这种情况下，他发病率要高的。
Was it analyzed like a subgroup of immigrants or new migrants versus residents, citizens, permanent residents?
These were, sorry, I should have told you, these are only citizens and permanent residents in this analysis.
所以刚才可能忘了介绍那个背景，就是说这个参加国家筛查项目的只有公民跟永久居民，那些所谓的新移民啊，都没有在内。
There are, I didn't show you, but there are differences in outcome depending on the three major ethnic groups, Chinese, Malay, and Indians. They present differently and their outcome is different.
所以他们也有做了对比，华人、马来族跟印族，他们之间也是有所差异，就是那个生存率是吗 ？The difference in survival？
Yep.
就生存率是有
Difference
差
in
异。
presentation, difference in survival.
然后它的那个表现，它的那个表现的时候的那个肿瘤的那个分期也有所不一样。Yes.
So, in your program, what's the starting age of the screen and what's the frequency of mammography?
So breast screen Singapore is from age 50 to 69, a mammogram every other year. But for women that show up, but they're not invited, between 40 and 50, they will do a yearly mammogram for them. And I think that's based on the randomized trial where the biggest decrease in mortality is between 50 to 70.
So, the risk of breast cancer, high-risk women to give high frequency of.
The way that most national programs go, they ask simple questions. Are you a woman? Are you the age of 50? Or whichever, and that's it. So there is no other risk assessment that is done.
So since the coverage of the screen is very low, just
Yeah.
like 6%.
Yeah.
Do you think it's one reason because of the awareness of the screen value?
We don't think so because in surveys that are done, if women are asked about screening, they will answer that yes, I know that screening exists, but we don't understand the disparity between knowing about it and not showing up for it. We don't.
Just maybe they are afraid of the radio harm because in our life, some people say that if we do more mammography, they will receive more.
需要我翻译一下吗？所以刚才这位老师问的就是说为什么那个覆盖率那个参与率那么低？然后他们教授说，基本上呢，你去问这个妇女你愿不愿意做筛查，他们说愿意的。 但是呢，实际行出来是很低的。他们说愿意的是40%，所以知而不行是现在我们新加坡所面临的问题。所以至于从知到行之间有什么出了什么问题，现在是还不太明确。所以刚才这位老师问是不是因为什么放疗、辐射、射线。
One difference between all of the programs that have high participation rates is that they are all free.
他也提出说，在欧美啊，他们就是这些筛查都是免费、全免费的。
But that may not solve the Singapore question. We don't know.
但是假如照搬在新加坡用这样的方法呢，也未必能够提高那个参与率。
Just $33 for Singapore. It's
Yeah.
not that much.
这新加坡的文化不容易。
Yeah. Yeah.
这位老师。
我想请问一下，就是那个你们在做这个乳癌筛查的时候，就是单纯的只是用木靶来做筛查，还是还有别的方法结合在一起呢？
So in the BSS, it's mainly the mammogram, right? Is
Yeah.
there any other screening methods that you use?
For breast cancer? No. There are no other evidence-based screening methods besides
因为从
mammograms.
循证医学的角度呢，只有木靶是有这个循证依据，可以所谓的普及化的来做筛查，其他的筛查方法都没有这样的循证依据。
So,
对不起，你要接着问吗？
但是我插一句，就那个杨主任问的这个问题，应该说的你说的木靶才循证液，但是我们就是从中国来讲的嘛，筛查那个权威就是进行了52个省的一个筛查，一直到现在都在搞。那现在统计下来对于中国的女性的嘛，我们现在的结论就是木靶加 B 超是比较高的。
So now in China, they have increasing evidence showing that mammogram has to be combined with ultrasound. 你指的是哪个年龄层的？
我们在那个年龄是36到65。
So from 36 to 65, in their recommendations, they will use mammogram plus ultrasound as the means of screening. What do you think?
if I'm just for screening, I would only do that if a randomized trial was able to demonstrate that it works.
所以他说，假如这个数据它的来源是一个所谓的随机对照前瞻性的研究，证明木靶加上 B 超确实是有所谓的循证基础，他才会说我们可以考虑把它弄成一个国家普及性的。
Because now it gets complicated.
因为这个有好多的复杂因素要考虑。
Breast cancer at younger age is uncommon.
因为在年轻妇女，虽然说是有个体的案例，但是它的那个整体来说，它的发病几率啊是相对的比较低。
So now
就是你这个就是在中国的女性的嘛，她的乳房一个是偏小，而且她的那个致命性的腺体比较偏多。
So she's bringing up this other issue of denser breasts.
Yes.
As a risk.
Yeah.
For,
Screening in a younger age group, you have to consider the harm you're doing with screening.
所以我们在谈筛查的时候，不单是谈它的益处，也要谈它的害处。
Ultrasound is very, very sensitive.
所以敏感的一种手段。
But it's not specific at all.
但是它的特异性非常差。
So what happens if you use ultrasound as a screening tool is that you will find many different lesions that you're not sure if they're cancer.
所以用 B 超来做一个筛查手段，而且你普及的话呢，你会发现过度诊断。
Which will result in many biopsies.
然后过度诊断就会导致。
And with very uncertain chance of decreasing the risk of death.
然后至于这个过度诊断、过度活检，至于是否能够真的是影响你们国家的妇女的。
I would be skeptical in including ultrasound as a screening tool for breast cancer.
所以针对刚才你问的，所以这个木靶加上 B 超，他有什么看法？他说他还是非常保留他的意见。对。
And also for the younger age group.
特别是对于年龄比较低的啊，比较年轻，他的可能那个弊大于利。
常态做这个钼靶检查，因为它有射线。就是另外一个就是人种的一个差别，就是亚洲妇女和欧洲的妇女，她的乳房的致密度，比如说欧洲的妇女可能她是以脂肪为主的，然后我们亚洲的妇女是腺体为主的，然后就是那个脂肪为主的，它是什么呢？就是钼靶比较敏感，是吧？然后我们这边的好像就钼靶有的时候它就又有遗漏，就是假阴性，其实本来是讲假阴性可能病人会比较多。
So she's pursuing this problem of Asian breasts being more dense, Caucasian breasts being more fatty.
That's okay.
So mammograms, is there a higher false negative rate for Asian breasts?
I don't think so. I don't think it's a huge problem if you start screening from the age of 50. But to be fair, there isn't a single randomized screening trial in an Asian population using mammograms.
所以他说，根据现有的循证依据的话呢，他认为刚才您提出的这个问题呢，基本上还没有任何的，就是非常高质量的循证依据来断定说这个刚才你提出的这个问题是否确实是个问题。除非是现在有一个中心或者多中心或者中国愿意把它做成一个随机对照前瞻性的大型研究，用钼靶。
Although it's intuitive to use ultrasound, I would be very, very cautious in using ultrasound for screening.
所以他还是认为说 B 超它的那个局限了
那现在钼靶检查一般一年可以做几次呢？
So like how frequent do you think mammograms can be used safely, rationally?
The amount of radiation exposed to the breast is very limited, so inducing cancers does not seem to be a problem.
Like is there upper limit or dose?
Okay. It depends on where you are in the world.
所以
How often you do it.
这个就跟你在哪个国家了，就是说你一年内你可以做几次啊 ？OK 啊。
So the
So,
most
say for example Singapore.
Singapore 50 to 70 every other year.
最多不要超过几次。
Like what's the maximum number of mammograms you can have in a year? From a safety perspective.
You should have no more than one mammogram a year.
所以一年不要超过一次。
No, there's a slight variation. She's not asking for what the recommendation is. She's asking for what the safety is.
Yeah.
Radiation dose.
Probably 60 to 80. You can get 60 to 80 mammograms a year
OK，
safely.
每一次的钼靶，它的那个辐射剂量低到一个地步啊，假如你真的要的话，每年一个妇女可以做上达
60 to 80.
60到80个
Yeah.
也不会有问题。
都没问题。
But our recommendation is do no more than one, which means that we have a huge safety margin.
所以当然这个国家筛查项目说一年不可以超过一次，所以基本上是非常安全的。
所以刚才我们说的那个，比如说你13年到03年到13年到
02到10啊。
Okay.
02到10。
So
比如说我们已经发现了这个包块，那我们每次来做的这个复查，我在追踪嘛，是不是？在追踪这个过程当中，我们还是用钼靶来做追踪检查。
OK， 就是发现了包块是吗 ？So when this
你的
woman
这个生成率
是因为钼靶而发现，还是她检出她自检？
检出以后，我不是一直在追踪，是治疗以后的追踪。
哦，治疗以后，所以您指的是治疗以后，他已经发现是乳腺癌，治疗了，然后
它的生成率还有多少？
治疗后的追踪。所以您问的是这个筛查项目的生存率，还是个体的？就是说他检出了之后。
刚才我就说您说的这个生成率是治疗，就是筛查以后治疗。
OK， yeah。所以您的问题是这个生存率是
我知道了，我清楚了。
OK， 所以还需要澄清吗？他那个生存率 OK。Yeah， so basically she has got her answer.
Yeah. So I just want to extend. The harm with mammograms is not radiation.
所以这个他要出，也谢谢你刚才提出的这个问题。
The
所
harm
以
that
他要带出的就是借题发挥了啊，就是说其实钼靶它的最大的伤害不是辐射。
the harm with mammograms is possible overdiagnosis.
所以它的伤害是过度诊断。
unnecessary biopsies and worry.
不必要的活检，以及所造成的焦虑。
Yeah. Which is an even bigger problem with ultrasounds.
那所有检查都存在啊，我觉得。
所有的检查都存在，特别是那些特异性非常低的，好像 B 超。
Okay.
好，谢谢。
包括磁共振是吧？
哦 ，she's asking about MRIs now.
Oh, now it gets even more complicated.
磁共振更敏感。
Actually, the specificity of MRIs is quite.
So there are ongoing randomized trials for dense breasts using MRI, but the results not out yet.
所以现在刚才您有提到那个所谓的密度比较高的乳房，所以现在正有人在用那个核磁共振的筛查手段，在正进行这个随机对照的研究，但是结果还没出来。